Thank you, Laura.
Thank you. You did well with the name. Nobody can ever say that. Thank you for allowing me to speak to you today. So I'm going to talk to you a little bit about the experience we've had with introducing LVADs at our centre in Manchester. So for those of you not as familiar with the equipment itself, this is the HeartMate 2 LVAD, which is the LVAD that we primarily used. We've now started implanting the HeartMate 3 as well as the HVAD. But it just allows you to see a little bit of the equipment that we have to deal with in our rehabilitation. So we started implanting the LVADs in 2010, which was initially 3 in the first year and then 1 in the second year. And then since then, the programme is rapidly expanding. And in the last year, we implanted 16 LVADs. Initially, once the patients were ready to go home, we found that we tried to refer them for cardiac rehab and we just got a point-blank refusal. Nobody was willing to accept these patients once they were discharged home. Our specialist nurses did an audit along a similar time frame, which showed how they were all putting weight on. And the challenge for us was we had this increasing pool of survivors, all living at home with an LVAD, getting onto the transplant waiting list and not being fit for surgery, mostly due to an increase in BMI. So the importance of cardiac rehab and exercise after LVAD implant is fairly well documented. It's increasing every year. We're dealing with a deconditioned group of patients that do improve in terms of VO2, but we know that they are sedentary individuals. Their steps per day are far fewer than the general population or recipients of heart transplantation. We know that cardiac rehab after an LVAD can improve exercise capacity. It can help to prevent weight gain alongside a multidisciplinary approach. And the trends are that they do improve functional peak VO2 and quality of life as well. So we know that it's an important part of their recovery. So to try and encourage cardiac rehab teams to take our patients on, we introduced a half-day training session for teams to come to our centre and learn a little bit more about the LVAD devices. We started off with half-day training sessions run by myself and one of our specialist nurses. The feedback we had was excellent, and the teams that attended were then really keen to take our patients once they understood the device a little bit more. The uptake of patients going for rehab improved, and up to date we've trained 18 teams. So a couple of the slides there just show you briefly what we cover in our sessions. Anecdotally though, we were getting reports back from our patients that some of the sessions were too easy and that they weren't completing all of the full course of the rehab. So we wanted to look a little bit more into what we could, where we were at and audit what our patients were actually doing. So we implanted 38 LVADs between 2010 and 2014. Mean age was 47. 89% of our patients with an LVAD survived hospital discharge. Only 28 of those were actually fit for cardiac rehab, so the extra 6 patients had either died in between discharge and going for rehab, or they were suffering from severe right ventricular failure. A few of them had cancer, or stroke was the other thing that we'd experienced. And of all those, only 16, so 57% of those who were fit to go actually attended that initial assessment. The 2015 data isn't complete because I submitted this before the end of the year, but that was the number that we implanted over the course of the years. This just shows you basically the patients who were actually fit, and then the percentages at the bottom of those actually attending their initial assessment. So we've gone from 2010, where 0% of our patients were going for rehab. 2012, we managed to get 57% of our patients into rehab, and it was towards the end of 2012 we implemented our education programme, and from then you can see a big jump into the percentage of patients who were getting into that rehab programme. The other thing that we looked at was the time it was taking to get people in for their initial assessment. When we first started training teams, we were still finding it was 172 days from discharge from the hospital to attending that initial assessment. And we've got that down now to around 100 days, and I'm confident the data for 2015 is even lower than 100 days. In comparison, the data for bypass graft patients, or MIs, or PCIs, is roughly, I think, around 50 to 60 days, and that's from date of procedure or date of MI to date of starting rehab, whereas this is from discharge, so there's a little bit of difference in the data, but we're still well above all the other diagnoses why patients might go for cardiac rehab. So there's no actual guidance in the literature about the optimum time to start rehabilitation, so we encourage teams as soon as they can get the patient in to get them in for that initial assessment. We do believe there's probably a small benefit to a patient having a period of time at home with the equipment, adjusting to the equipment, allowing them to settle their INR. They have frequent drive-line dressing appointments, which can take up a lot of time. So a small amount of time before they start rehab, I don't feel is too much of a detriment to them, really. But the biggest issue we feel is the time it actually takes to get hold of a cardiac rehab team, get them to agree to come for training, book a date that we can, we're really accommodating. I've been to the Isle of Man to train a team, so they didn't have to come to us. But the biggest issue is really getting the team to us for that training. But as we get more and more teams that are familiar, so we've now got 18 trained teams, the quicker they're seeing our patients and the more benefit to the patient. The other issue was of those actually turning up for their initial assessment. We'd heard that there were a few not bothering to go back. So we looked at the actual adherence and who was going. So we defined completing a cardiac rehab programme as attending 8 or more sessions. And 10 of our patients achieved that. So that's only 37% of those fit to attend. Now, comparing that to the general cardiac population data is quite difficult because the National Cardiac Rehab Audit data just talks about people who joined in with rehab. It doesn't necessarily define it as those who've completed the course. But that is below, bypass graft patients, it's about 70% of those who'll go to cardiac rehab. The average of bypass grafts, PCIs and MIs is about 43-44%. So we're still below that attendance rate. But the mean number of sessions attended for those who did go was 16, ranging from 1 to 46. So once we got people through the door, they went and they attended a really good number of sessions. It's getting them there in the first place that we find is the issue. So why aren't we achieving higher rates of attendance? So we're still finding some centres that aren't willing to accept our patients, that aren't maybe funded for heart failure, and they class our patients as heart failure. The way we've got around that with some places is if they've had an MI before, then we've managed to they've classed them as an MI patient. So clinicians worrying about the LVADs that they just don't know very much about them, or that they're not able to release their staff to attend training. That's still a problem. Like I say, we've tried to move mountains, we've gone to them, but it's still not always that successful. Medical problems, our readmission rate at Manchester is actually the lowest in the country, I'm led to believe, but we do still get the odd readmission, and that's usually for other issues and maybe not LVAD related. We've had some patients listed for urgent heart transplant and then other comorbidities, so we've had a few with cancer and a few strokes as well. And then patient choice, so patients just declining the referral for social reasons or reasons unbeknown to us, saying that anecdotally some of the classes are still too easy. So one of the ways we're trying to address that is every time we run another training day for a new team, I email every other team who's been for training and offer for them to send any new staff or anybody who wants a refresher, particularly now we've implemented the new HeartMate 3 device. I did a brief look at whether the age of the patient was affecting the adherence, and we actually found that it was the younger patients that weren't necessarily following through with their rehab. So that's one thing that we possibly need to address, is tackling our younger patients. These are a couple of our poster boys that I just thought I'd throw in there, who don't mind us showing their photographs. And we do have a good percentage of our patients who are very active, cycling all around Europe, attending the gym regularly. So it's not all doom and gloom. Quite a few of our patients keep themselves in good shape while they're on the waiting list. That's it. Thank you very much.